It's truly a pleasure to be here, and none of which would have been possible if it weren't for our beloved Swami making all of this possible. Here I was trying to take a vacation, and then, of course, he said, you got to present, and here I am. So I had the opportunity to meet your director and your co-director, a cardiothoracic surgeon and a plastic surgeon, I guess. So I thought I'll start off with a joke. I normally have that tradition. So we have a 30-year-old female who ends up having a heart attack, and she's rushed to the operating room, and she has a triple vessel disease. So they have to do a bypass. She has a near-death experience as she's in the OR. And she sees God and says, God, is it my time already? God says, not yet. You have 30 more years to live. So she says, since I have 30 more years, she goes to a plastic surgeon, gets a facelift, a tummy tuck, a breast augmentation, recoups from her surgeries, leaves the hospital, is crossing the road, gets hit by an ambulance, and dies. She goes to heaven, sees the Lord, and she's very angry. She asks God, I thought you said I had 30 more years to live. God looks at her and says, oops, didn't recognize you. The moral of the story is that things that may seem obvious are often missed, which clearly bodes to what I'm going to talk about today, about physical and mental health. Very often, we often think about these as kind of, siloed approaches. We either are focusing on, if you're a cardiologist, focusing on the heart, versus if it's a psychiatrist, focusing on the behavioral health issues. But we also need to understand that there's a bidirectional relationship between behavioral health, mental health issues, as well as physical health issues. If you look at the world population, 330 million individuals all over the world do suffer from depression. The World Health Organization has predicted that by the year 2020, depression is going to be the second leading public health concern next to heart disease. So clearly, I'm going to use both depression and heart disease as a prototype to talk about both of these illnesses and the relationship that we have between the two, as we look not just at the pathophysiology of it all, but also looking at holistic approaches to how do we go about addressing these issues together as multidisciplinary teams. So here we have kind of the average age of onset of depression clearly is about in the mid-20s. No matter which physical illness you look at, chronic pain, very high comorbidity. Parkinson's disease, 50% of individuals with Parkinson's do go on to have depression. Strokes. Depending upon the polarity of the stroke, if you have a left-sided stroke, you're more likely to have depression. Tumors, epilepsy, generalized seizures, very strongly correlated to depression. Myocardial infarction, 50% of individuals who have an MI do go on to have depression if left untreated. Diabetes, anywhere from 20 to 30% comorbidities. Medications, beta blockers in very large doses, 80 milligrams, 120 milligrams of propranolol can result in individuals getting to feel depressed. Hypothyroidism is one of the most common causes. If you didn't do a TFT, you would never find out that that was what was responsible for an individual going on to develop depression. Now, this is an interesting study done in Sweden, looking at mortality in mood disorders. And if you look at endocrine, cardiovascular, cerebrovascular disease, the standardized mortality ratios for those with unipolar and bipolar depression is about 2-fold higher compared to the general population. So they're already at a heightened risk. What about patients with schizophrenia? A patient with schizophrenia is at a 2-fold increased risk for obesity, a 2-fold increased risk for diabetes, 3-fold increased risk for hypertension, anywhere from 2 to 5-fold increased risk for hyperlipidemias. So if a person with schizophrenia, maybe undiagnosed schizophrenia, comes into you with any of these issues, and they have all 5 of these risk factors, their cardiovascular morbidity mortality rates goes up anywhere from 10 to 14 times, which means the life expectancy is about 20 years shorter than if you did not have a mental illness. So it's extremely important for us to recognize this relationship between the two. How does depression, untreated depression, have an impact? Clearly, when we look at comorbidities with medical illness, if you're depressed, you're more than likely not to take your medications, your cardiovascular medications or your diabetes medications. Similarly, rates of suicides are extremely high. 35,000 suicides in the United States alone. The rates of suicide in India are significantly higher, especially during exam time. right? Yes, when you look at young children as well as teenagers and young adults, every time I come in, I get interviewed by Hindu or Indian Express based on the rates of suicides that are occurring so rampantly in India. And again, one of the reasons for that is the gene-environment interaction, psychosocial stressors that have clearly gone on to increase based on societal pressures, other kinds of things that are happening around you, not just what you've inherited from your parents, but also the environmental insults that you've gone on to suffer. So irrespective of whether you look at depression, cardiovascular disease, diabetes, all of these are lifestyle diseases. So it's extremely important for us to start looking at integrated approaches to addressing some of these issues. And of course, psychosocial issues such as divorces, loss of job, unemployment, all of those do contribute. So there are several roadblocks to diagnosing depression in a primary care clinic. Very often, if you are diagnosed with cancer, we trivialize it by saying that you have cancer and hence have a reason to be depressed, right? So to me, it's really, that warrants us to kind of, have an in-depth assessment to see, is this individual really have neurovegetative symptoms of depression for a period of 2 weeks, which clearly has an impact on their social and occupational functioning. That's very important. Unless until you address the depressive symptoms concurrently with their cancer treatment, the quality of life is extremely poor for those individuals. There are a number of reasons for misdiagnosis. Stigma. Now, no matter how much progress we have made in the field of medicine, whether it is understanding the biological underpinnings of an illness or looking at various treatment armamentarium, we still continue to grapple with issues pertaining to stigma when it comes to mental illnesses. And I think it really takes a lot on our part as a society, as a community, to be able to spread awareness, to be able to address some of these issues. And very often, when a person walks into a primary care clinic, they may present not necessarily with depressive symptoms, but more so with somatic symptoms. Like I have GI distress, or I have pain syndromes. So very frequently, that's something that eludes further investigation to see, is this individual, do they have any kind of mental health issues? So let's kind of now transition to medical comorbidity. So if you look at MI, we talked about increased morbidity and mortality if you have comorbid depression with myocardial infarction. Congestive heart failure can also result in increased prevalence of depression. If you look at post-stroke, AIDS, patients with AIDS do go on to have depression. I mean, there's clearly a reason to be depressed, but again, that intensifies. So here are some of the prevalence rates, whether it is MI, unstable angina, congestive heart failure, cardiac cath, status post cardiac caths, bypass surgery. So you can see anywhere from 20 to 50% of them do go on to have comorbid depression. This is the famous Framingham study, one of the seminal works that was done, which continues to go on. And what you see here is 6-month and 18-month coronary fatalities after acute MI. And the yellow bars represent depression, those who had depression, and the orange bars represent those who were non-depressed. 6 months into, you see those who were depressed had higher fatality rates, and if you look at it 18 months into, significantly higher. Now, depression. So we have looked at cardiovascular disease resulting in depression. What about depression resulting in cardiovascular disease? So to understand the bidirectional relationship here. So as you can see, depression increases risk of cardiovascular mortality. So those who clearly were non-depressed is the light blue bar. The purple bar is minor depression, so not necessarily full-fledged depression. And then, of course, the white bar is major depressive disorder. So those who had no pre-existing cardiac disease and those who had pre-existing cardiac disease. And clearly, if you had major depressive disorder, you are more likely to have a cardiac event. So here is an interesting kind of schema of the relationship between the HP axis, the hypothalamicpituitaryadrenal axis, which plays a role in stressful life events. So anytime any of us are exposed to stressful life events, you have the activation of the hypothalamus, which then releases CRF, corticotrophin releasing factor, which activates the adrenal, clearly pituitary gland to release ACTH. ACTH in turn activates the adrenal glands, adrenal cortex, and the adrenal medulla to release cortisol, as well as norepinephrine, epinephrine, and dopamine. So this is what kind of the stress axis, the stress diathesis cascade looks like. But as you can see here, you can also look at what does it do for cardiovascular disease. Increase in cortisol can also result in arrhythmias, right? So you have kind of epinephrine, norepinephrine, so you are at an increased risk for myocardial ischemia, right there that you see. It also increases pro-inflammatory cytokines. So what can they result in, especially if you are looking at tumor necrosis factor alpha or various kinds of interleukins, cancer. So again, just to give you an example of how these two illnesses, be it physical illness or a mental illness, are interrelated. Platelet activation can occur in individuals with ischemic heart disease as well as those with depression. So if you see the control group, those with just ischemic heart disease and those with ischemic heart disease and depression, significantly higher platelet factor 4 as well as beta thromboglobulins. So increased risk for atherosclerosis is what you're looking at. How does that translate into treatments? So if you are depressed and you have also had an MI, you're more than likely to be non-compliant to the regimen that your cardiologist recommends, whether it is with regards to your diet, exercise, medication compliance, you name it. So all of those are significantly reduced. So here is what Darwin's theory of evolution looks like in the 21st century. We've gotten to be a fat, diabetic society with increased risk for heart disease and depression, of course, sedentary lifestyle. And here I've introduced KFC, McDonald's, which clearly have penetrated into the Indian markets too. So it's extremely important when you understand pain and depression, they're truly intertwined. Be it norepinephrine, epinephrine, serotonin, which plays a role in both of these syndromes, but also neurokinins, which play a very important role, neuropeptides and neurokinins. So again, there are a number of treatments that we are looking at predominantly to see, do they address not just pain syndromes like fibromyalgia, for example, is a very good example of that, which also has a very high comorbidity with depression. So trying to look at both of those and how do we go about addressing some of these with various neurotransmitters that do have an implication in each of these disorders. So if you look at pain and depression, those with no complaints, those with mild complaints, pain present most of the time. Oh, there is, okay. I wasn't very sure. Is this the one? Oh, perfect. And then, of course, pain resulting in functional impairment. As you see, even if you have mild complaints of pain, you clearly have an increased risk here. What about risk of suicide if you had both pain and depression? Whether it is wanting to die, whether it is suicidal ideations or suicidal attempts, significantly higher right here if you had both comorbid pain and depression. Pain also predicts a poor response to depression. So it's extremely important to pick the right treatment. So agents which have both norepinephrine and serotonin, so SNRI, selective serotonin and norepinephrine reuptake inhibitors, patients do much better on those if you have both of these comorbidities. How do we go about screening for depression? Clearly, you have a number of scales that we use. The PHQ-9 is something that's very easy to administer, the patient health questionnaire. It is available in the public domain, so each of you can have access to it if you just Google PHQ-9. Very easy. It takes about 5 minutes for the patient to fill in. They can be sitting in the doctor's office waiting for the doctor, and you can just ask them to fill it in. Based on the cutoff, a score of greater than or equal to 10 clearly gives you some kind of an indication that they need to be assessed further for depression. QIDS is another, the quick inventory of depressive symptoms, which is the self-report. And here is what the PHQ-9 looks at. It addresses various neurovegetative symptoms of depression: sleep, lack of interest, energy, appetite, concentration, suicidality, all of those. And this is the QIDS, and that has a total score of about 27. If you use the PHQ-9, which is truly universal. So it's extremely important once you've diagnosed an individual with depression to be able to have a therapeutic alliance, no matter which illness. Very important. I had the wonderful opportunity to meet with Dr. K. Narasimhan, who heads your mobile hospital. units today. And it's just it was just amazing sitting in there when, as he and his team were talking to the patients, the amount of love and the trust and faith that the patients have in their physicians, that is extremely important. If you do not have that kind of a therapeutic alliance, more than likely, one, your patient is not going to keep up their appointments with you. Two, they're not going to take their medications, right? Non-adherence is very common, irrespective of which illness you look at. So that's extremely important. And also being able to explain what the illness is in layman's terms is very important. And here is kind of just the various treatments. So when you look at depression, there has been a paradigm shift in how we look at treatment success. We are no longer satisfied with response, which is a 50% improvement in depressive symptoms. We are now looking at remission and recovery. Recovery is improvement in quality of life. So whether it is, you can apply the same to cardiovascular disease, you can apply the same to cancer. So quality of life is very important. Do they enjoy spending time with their family? Have they been able to enjoy what they do when they are at work? So those are the kinds of things that we need to be looking at, not just focusing on just symptomatology or symptom improvement. So of course, 21st century, very blessed. We have about close to more than 30 antidepressants that are out there. Same thing holds good for cardiovascular disease or for any of the hypoglycemic drugs. But it's also important to focus on non-pharmacological approaches, whether it is psychotherapy, various kinds of psychotherapy, but also I think as a part of Swami's institution, we also need to look at how do we start incorporating spirituality into all of this. So it's extremely important to look at the mind-body-spirit connection. So when you are able to address all three of these together, the eventual outcome, be it in the physical health domain or the mental health domain, is going to be significantly better. We all know that. So we are truly blessed to be a part of such an institution and to have kind of the grace of Swami be able to teach us some of that and the value that it truly adds to the treatment armamentarium. So here is what integrated service delivery needs to look like. So you do a screening, you do an assessment, whether be it a medical comorbidity, be it an emotional health comorbidity. And then you also need to start to have a dialogue about lifestyle changes. We had a gentleman who was in his 30s this morning who had an MI. And Dr. Narasimhan was talking to him about the need to switch from a non-vegetarian diet to a vegetarian diet. That's a conversation we need to have. Very often as physicians, we all get to be very busy, right? We're kind of constantly having to see one after the other. But spend some time with the patient to have that level of connectivity. Very often we become professionals, and in this kind of automated world, we're kind of constantly rendering our professional advice. We talked about advice a little earlier. So it's very easy to do that. But to me, you also need to interact at a human level. That level of connectivity. At the core, every human being is good. So how do you connect and kind of call upon that individual so that they can understand what they need to do to better themselves? So how does one start to include some of these elements, complementary alternative? At the university where I practice, we have a National Institutes of Health CAM Center, which is Complementary Alternative Medicine Center. So we've been looking at various kinds of alternative medicine treatments and what does that really do to various disease states. So we are looking at resveratrol, which is found in red grapes. It's also found in wine. And how does that have an impact on cancer, on demyelinating illnesses like multiple sclerosis? What are the implications of those? We also have a number of our public health researchers who are looking at turmeric. Turmeric, we are very fortunate. We include turmeric in our food. So what does that really do, whether it is in terms of preventing cancer, whether it is dementias? With increase in baby boomers, Alzheimer's disease is going to be on the increase. We don't have that many geriatric psychiatrists or geriatric medicine folks. So how do we go about addressing these? These are simple things that we can kind of start to incorporate within our treatments as we start talking to our patients. So that's going to be very important for us to be able to do that. We also need to remember that if you're looking at, I'll give you an example of diabetes and depression, for example. So there is an increase in insulin growth factor in patients with diabetes. There is also a reduction in BDNF, which is brain-derived neurotrophic factor. So if you have an individual with depression go through an MRI scan, you will find atrophy in certain specific regions of the brain, like the hippocampus, for example, which is responsible for memory. So what do patients with depression complain of? They have memory problems. So to me, it's like if you have, when you look at this bidirectional relationship, be it diabetes and depression, how do we go about fine-tuning both of those, be it with traditional approaches, with complementary alternative medicine, with lifestyle, and of course spirituality, which needs to be a core component, yoga. I was visiting the National Institute of Mental Health in NIMHANS at Bangalore, and they are doing some very interesting work looking at, again, more so focus on mental health issues, depression, schizophrenia. They're using the technique called Sudarshana Kriya that Sri Ravi Shankar uses. So what does that really do to the different parts of the brain? About 15 years ago, there was an interesting study in JAMA, which is a Journal of American Medical Association, wherein they looked at patients who were admitted to the ICU after an MI. So they divided this cohort into two groups. One group had preachers pray for them, what is termed as intercessory prayers. The other group did not get it. So the one group that did end up getting prayers did much better. The mortality rates was, much, much lower compared to the group that did not get it. So clearly we need to understand that prayer does, a lot of things that sometimes is beyond human kind of capacity to understand. But of course, we've been fortunate to be under kind of, Swami and his divine kind of grace to be able to see a lot of these miracles happen. And I'm sure you at Super Specialty are more blessed to be able to have that experience firsthand. Then, of course, there is the field of personalized medicine, which, based on kind of gene sequencing, genome-wide association studies, can we predict which medication you're going to respond to or which illness you have a higher predilection for. For example, if you have the serotonin transporter gene polymorphisms, which is you inherit one allele from each of your parents. It comes in two alleles, a short allele and a long allele. So let's say I end up inheriting two short alleles from my parents. I'm at a higher risk for depression. Okay? Versus if I get two long alleles from my parents, that in a sense will confer resilience for me. Resilience for depression, but not for hypertension. So we need to remember that. So again, I think science is evolving. There's a lot that we are trying to explore. And maybe, about a decade down the road, we might have some answers to some of this in terms of trying to look at personalized medicine. Yes, I can say for sure, based on this genetic makeup, you are at a higher risk for a certain disease. And based on your genetic makeup, I can also tell you which medication you're going to have side effects from and which medications you're going to respond to. So I think at the end of the day, it's important to start customizing treatment. No one patient, one size does not fit all. We all know that. A person who does not respond to a beta blocker may respond to an ACE inhibitor. So it's extremely important for us to be kind of fine-tuned until we get to genetics, which clearly is not ready for prime time yet, to be able to kind of take a look at some of that as we try to adopt holistic approaches to treatment. So let me kind of transition from here to innovation. How do we innovate to integrate? Look at research. Very often people kind of think when you talk about research, it's traditional research. You're either doing translational work or basic bench-side research or clinical trials. But to me, I think we have gone from there to implementation science, which is evidence-based practice, randomized controlled trials, meta-analysis, systematic reviews, to improvement science. Now, in the US, everything is measured by quality. How much of an improvement did we result in based on what we treated them with? And the same thing, we really need to hold ourselves to that bar in terms of, really, we provided this medication, but did that really improve? So how do we gauge that improvement? So that's improvement science. And then, of course, you have personalized medicine that I talked to you earlier about, and population health. So can we look at geomapping and say, okay, there is a higher predilection for diabetes in Anantapur? And how do we go about targeting? Is it more psychosocial stressors, what they eat, or is the lifestyle kind of impacting that, and how do we go about addressing some of that? So how can we start applying technology in addition to other interventions? So I'll talk about some of the innovative technologies that we've been involved with. So ours is a small state of South Carolina, which is north of Florida and south of New York. So we have 50% of our state is rural. Okay? So it's extremely important to be able to have those folks who are located in rural counties have access to healthcare. That's very important. So we have a couple of projects. Telestroke is one, and then, of course, Telepsychiatry, which I am a principal investigator for through the National Institutes of Health. So if you look at stroke, we are actually the buckle of the belt when you look at the stroke belt. So North and South Carolina, we have the highest prevalence of strokes. So what does when you look at the National Institutes of Health, what do they recommend? When you look at an individual being brought into the emergency room, door to needle time needs to be less than an hour to be able to prevent any neurological deficits. Okay? So in an ideal world, that will happen, right? If that were not the case, like neurologists are very sparse in our state, so how do we go about making it happen? How do we leverage technology to be able to make some of that happen? And here is what we have created. We have created a spoke and a hub. So you clearly have the tertiary medical center, the referral hospital. From the local hospital, we're using a laptop, webcam. They have the MRI scans that are done to wherever the patient comes in, and that gets sent to the referral hospital, and our neurologist gets to read and see if this is a patient who clearly warrants TPA. So this way you have prevented the time lag between them having to travel to another tertiary hospital. And the outcomes are impressive. So we've been able to serve significant amount of physical functional deficits for our patients, but also in terms of costs. So I'll talk a little bit about the telepsychiatry project that I'm a part of. So this happened in the late 2000s. So there was a time wherein there was deinstitutionalization. So all the long-term psychiatric hospitals were closing down. They closed down much earlier in the Northeast, but not so much in the Southeast. So it was about a decade later we started closing down because of budgetary constraints. So when you close down these beds, where are these patients going to go? They're going to come to the emergency rooms, right? So hospitals and EDs. So we said, we really need to start thinking outside the box, and how do we go about addressing this issue? So we approached an endowment called the Duke Endowment, which has been funding projects both in North and South Carolina. And we said, we really would like to utilize technology to be able to see if we can beam in a psychiatrist into these emergency rooms. So there began our journey into a public-private academic partnership. So we had to have the Department of Mental Health, which is a state-run agency, which clearly caters to the entire state of South Carolina, which has inpatient hospitals, outpatient mental health centers. We contacted the South Carolina Hospital Association, which has about 65 hospitals, and then academia, which I'm a part of. So we sat together, and it was a lot of brainstorming, and how do we go about working towards a common goal? Not easy. So one good thing that, of course, being in Swami's fold, as well as what some of my mentors, who I'm very grateful to have taught me, is that anytime you're in a meeting, leave your egos outside the door. You go in there, work towards a common goal, and make it happen. Improved outcomes. So we sat together, and again, we were able to come together as a group. So the Duke Endowment funded us for this project, and around the same time, the National Institutes of Health was very interested in looking at how do we bridge the gap between policy, practice, and research. Very often there's a disconnect. When you do research, it's in a very pristine population. When you're looking at practice, it's different kind of patients with so many comorbidities. Where policymakers have absolutely disconnect from what is happening out in the trenches. So how do we kind of connect the dots between these three? So this is the state of South Carolina, and what you see is darker the color is the increased rates of discharge for behavioral health issues. So this is what NIH was very interested in. So we got a grant from the National Institutes of Health, and this was about a $1.4 million grant, the first grant that we ended up getting. And subsequently, we've had a $2.7 million grant to look at clinical outcomes. So these are the hospitals in the state of South Carolina, 65 hospitals. In an earlier study, what we had also looked at was that patients who came in with behavioral health issues had higher comorbidity for depression, for diabetes, for lipidosis, for various obesity, as well as for hypertension. So no brainer here. They're all kind of comorbid and bidirectional relationship between the two. So the uniqueness of our project was that nobody at that time really had ED telepsychiatry in 20 hospitals, which was wonderful for us. So far, we've seen about 22,700 patients, one of the largest studies that's been done in the world of that many patients being seen. So public-private academic partnership. We're also very blessed in our state to have a data warehouse which was built in the mid-90s using legacy systems from various state agencies. We were talking about IT. Is there a way in which we can build these large data warehouses at the inception rather than have to retrofit it? And then which would be extremely helpful. So we can take a look at an individual patient. So this is all these agencies, hospital systems, free clinics, you have the Department of Corrections, all of these pour data into this data warehouse. So we can look at an individual patient and say, okay, this is what it costs the state for this individual patient, for ED visits, or for going to see the primary care physician. So it's incredible. And I think you clearly are well positioned to be able to do something like this, given the fact that you have the mobile hospital, you have the super specialty hospital. If you build an IT framework, which truly you as a state can be a beacon for other states in India. So we developed all of this, the EMR, electronic medical records, so making everything seamless. So you have all of these consults that are queued in. The telepsychiatrist comes on board, takes a look at consult from county X. They can take a look at the data warehouse, which clearly has this rich data. They can see how many times has this patient been admitted in the past, what medications were they tried on. So this way, it's like you know for sure, here is what we can get them better with. So effective triage. So this way you keep them in there for a shorter period of time. So we got all of that going. And this was the first RO1 that we had from the National Institute of Health. And we were predominantly looking at length of stay, ED recidivism rates, does that reduce that in any way? And what about kind of from a budgetary impact? Administrators are always looking at how do we reduce costs. So we had to kind of pacify all of these in this various kind of stakeholders. So what we were able to show is that the length of stay, if you got seen by this telehealth provider, was 1.5 days shorter compared to if you did not have that service. The rates of follow-up, so they see them, they do their initial interview, they put in their electronic medical record note, which gets seamlessly transmitted to the ED physician. And the ED physician then provides their kind of whatever recommendations that was provided. They can then write the prescription for the patient. That happens, and then they are followed up at the local mental health center. 5-fold higher rates of follow-up. Just because you got seen by a professional or an expert in the field, they were able to keep their appointment. So 5-fold, that's pretty impressive. If you look at the cost, just emergency room cost and inpatient cost, per patient, it was a cost savings of $1,400. And we have seen how many? 22,700 patients. Over 30 million in cost savings. So what we already have shown is that it's a sustainable model. So we went back to the state. The state said, we'll put money in. The Duke Endowment, this is one of their primed projects because we've been featured on the Agency for Healthcare Research and Quality as a national model. So which has truly been incredible. And to me, one of the reasons for that is that everybody came together to make something like this happen. At the end of the day, we were able to make a difference in a patient's life. So that, to me, is extremely important. That's why we went into medicine, right? All of us went into medicine for that reason alone, not to make money. Money comes and goes. Morality comes and grows. And we were also afraid what about kind of, our own staff or staff in the emergency rooms? How savvy are they going to be with technology? Our kids, our nieces and nephews doing texting and gadgets is different. Our generation is very different. So to me, it was like, are they going to be comfortable using it? And what you see here is that anywhere from 80 to 90% satisfaction with technology, efficient use of time, comfort with telepsychiatry, improved patient care and services. What about patient's perception? Look at that. And there was a time wherein a patient had this interaction with the psychiatrist on the screen. And when they were done, they got up and extended their hand to shake their hand. They almost forgot that they were not in the same room with the provider. It's just incredible. So here is our humble effort in trying to bridge the gap between policy, practice, and research. So we have gone on to win a number of accolades, clearly. We have an autism project, too, and that won one of the Continuing Medical Education Awards. We've been awarded the American Psychiatric Association Award for Innovation in Healthcare Delivery Systems. So based on that, my thought was, how do we go about integrating physical and mental health care? So to me, it's like if we have technology, technology can be a blessing or a curse. Technology in moderation is good. So to me, it's like, how do we start incorporating some of these technologies to be able to better serve our patients? So creating a one-stop shop. So this way, the patient doesn't have to come to see the cardiologist one day, they don't have to come to see the GI person one day, or their primary care provider another day. So we thought about, here was a thought that I had, and which we have just begun this project. The patient walks into a primary care facility, so it's called a patient-centered medical home. The patient walks in, they're greeted by a health coach. Okay? So the health coach comes in and they have an iPad. So using an iPad, the patient can kind of, either sit with the health coach who can guide them, or they can do it themselves. There are two questionnaires, the PHQ-9 that we talked about earlier, and there's a questionnaire called GAD-7. It takes about 5 to 8 minutes to kind of just answer some of those questions. So based on the cutoffs, the health coach quickly calculates the total, and based on the cutoffs, they can get referred to the Department of Psychiatry, and a psychiatrist on our end can see the patient using telehealth. So we have the iPad on a pole. So the patient can be waiting in the exam room. They have the iPad right in front of them, and they get to be seen by a psychiatrist who's in another department. Okay, so that gets taken care of. Now, if the patient has cardiovascular risk, we also have trained the health coach in handheld ultrasound, which is called as the stethoscope of the 21st century, so to speak. So we have that, and so she runs the probe over the chest wall. Okay? So she captures the initial image of whether it's a person who comes in with congestive heart failure, left ventricular hypertrophy because of sustained hypertension. So she has that. There is a company which makes a one-lead EKG. So it's on an iPod or an iPad. So it's really neat. So it's like a credit card. The patient just holds onto it, right? As they hold onto it, you have an EKG tracing. It gives you a heart rate. So we have all of that done. They then have a kiosk wherein they can go. If you're a smoker, you sit in there. It's a web-based smoking cessation module. So you answer some questions. It customizes motivational interviewing. Motivational interviewing can be used for smoking. It can be used for substance use. It can be used for obesity. Okay? So there are lots of uses there. So it customizes it. They get to see their primary care provider or their nurse practitioner, and they leave. What we are now going to do is capture outcomes. So based on this integrated care using various technologies, have we been able to bring down their hemoglobin A1C? Has that been able to impact their lipid levels, lipid profile, so to speak, as well as their mental health parameters? And did that translate into reduction in ED recidivism? Because if you have somebody who was a diabetic and constantly goes to the ED for diabetic ketoacidosis, right? By capturing all of these, both their physical and mental health issues, were you able to avert some of that? So that's what we just began June of 2014. So I'll probably have by June of this year, we'll have some good data to be able to do that. And we are trying to customize it based on the clinic and their specifics, because it has to be customized based on the clinic too. So here is what the various technologies I talked about. So I'm going to stop here. I know I've saturated all your brains with too much of information, but I've truly been impressed by Mahatma Gandhi, who says, be the change you want the world to see. And of course, by Sir Winston Churchill, who says, you make a living by what you earn, but you make a life by what you give. And I'm incredibly fortunate to have come into Swami's fold probably in 1999, and to have served under his clearly leadership and his divinity. And to me, it's wonderful to have people like Dr. Valletti who are here, and very, very grateful to you to have given me this opportunity. Thank you, and I'll take questions.